7 in your book, and it talks about intro to cardiac catheterization. So first thing you need to know that cardiac catheterization is a process that doctors use to diagnose and treat certain cardiovascular problems. So during the time that you're getting the cath done, a long, thin tube that we call a catheter is placed in an artery or vein in the groin area, the neck, or the arm, and it's threaded all the way through the blood vessels to your heart. Now, the type of cath that the person is going to get depends on the indication, like what's actually wrong with the person. This could be done for the left heart, the right heart, or both sides. So they do this for coronary artery disease or ischemic heart disease. Whenever you have ischemic heart disease, it means you're not getting enough oxygenated blood flow to the actual muscular layer of the heart or the myocardium. They use it to check left ventricular function if the person has issues with that. They have valvular heart disease issues. If they have myocardial disease, because they're going to need to get a sample or what we call a biopsy, this is how they evaluate if the person has myocarditis. They also use it to verify and support other data that we've done before, like a regular echo or stress test. And then they determine the necessity of whether the person is going to need surgery or not. So let's first talk about the left heart. So if they're going to do a catheter for the left heart, they use normally the percutaneous femoral artery approach. That is the most popular method for left heart catheterization. So they make a small incision through the person's skin, and then the catheter is threaded through the femoral artery all the way to the aorta, the coronary arteries, the aortic valve, and to the left ventricle. So they use a pigtail catheter, and that's what a pigtail catheter looks like. Now, it's not just the left side. Let's say they're going to do a cath for the right side. When it comes to the right side, the most popular method for the right heart is the femoral vein approach. So most often they'll use what we call a Swan-Ganz catheter, and that's what this catheter looks like right here. And they will pass it through the IVC to the right atrium, through the tricuspid valve to the right ventricle, the pulmonic valve, and the pulmonary artery. And then sometimes the right heart cath can travel from the right atrium through the interatrial septum to the left atrium. It just depends on whatever information the doctor or the surgeon or even the cardiologist is looking for. And then we call this procedure a transseptal procedure. So not just that, there's the actual procedure itself. The cardiologist will use whatever procedure they deem best at the time, and the equipment that they're going to need is already going to be there. And so they'll have a needle guided wire. They're going to need like sheath and stopcocks and stuff. All of that you'll know when you actually start working. And then they'll guide the catheter to the left or right heart depending on what they need. So the cardiologist is going to use floor pedals to view the real-time X-ray images or fluoroscopy to film the study. And then he or she is also going to use like a digital device that we call sonography. And the floor pedals, they use it to view and read the study. Actual fluoroscopy is basically X-ray. And sonography is like what we have, that cine loop, except they're able to move back and forth depending on what they want to see. And sometimes it can be digital, which means they don't have the cine loop and they just watch it through a computer. Now, the fluoroscopy gives the doctor immediate visualization inside the body. So that way it's live, and if an intervention needs to be done, the doctor can then do it as soon as possible. So let's talk about cardiac angiography. That's what this image is right here. So the best cath technique to use to evaluate left ventricular function is it's a left ventricular angiogram, aka angiography. I'll talk about what these arrows mean here in a minute, but let me explain what the coronary angiogram is. So what happens is they inject like a radio contrast agent into the vessel, and it gives the doctor information on the ejection fraction, the wall motion, and it's normally very popular to use to assess the coronary arteries like it is here. So you see these very thin vessels. Look, it's big right here, but it's thin right here. It's big right here, but it's thin right here. Wherever it's thin at, the negative space, like this gray area, is because that space represents like plaque or atherosclerosis. Otherwise, it would be this big. So the small thinned out spaces are where the plaque is at. So if they find an issue, then there's different things they could do. They could do angioplasty, which is sometimes they call it PTCA, and that's when they inflate the balloon. And the PTCA stands for percutaneous transluminal coronary angioplasty, and you can see why they call it PTCA. But you should know that it's minimally invasive, and it's done to open up the blocked coronary arteries, which will then allow blood to circulate to unobstructed part of the heart muscle. Sometimes they can use stents, and other times they can do what we call atherectomy, and that's where they remove the plaque from the vessels. So if they're doing like a right heart cath, normally they want blood samples. They will use the catheter to repair a shunt. Remember, if there's a shunt, the person is going to have blood moving back and forth between the two chambers, and it's not supposed to do that. They can use it to calculate cardiac output. They can use it to measure the heart muscle sample. Like, let's say they've done transplant, but the heart didn't take and the body's fighting against it. So they'll know if there's a rejection situation going on. But if they're going to do it for a sample, they'll use what we call a biotome. That's a slightly different catheter. So for pulmonary angiography, they can use it to check to see if a person has an embolism. Remember, an embolism is like when a piece of plaque or thrombus breaks off, travels somewhere else and lodges in that coronary artery. They can use it to tell right heart pressures. They can also indirectly tell the left atrial pressure using the pulmonary capillary wedge pressure, but they use specifically a Swan-Ganz catheter for that. I'll talk about what the pulmonary capillary wedge pressure is. I think it'd be better if I explain that in lab. So for the left heart, they use they can use it for angiography. They can use it for intravascular ultrasound and pressure tracings of the left ventricle and the aorta. I'll show you guys the pressure chart here in just a bit. It gets a tad bit confusing, but it's actually not that bad. Just remember that you actually won't be dealing much with the cath lab. The doctor would be the person dealing with it, but it's good for you to understand what exactly they're doing so it can help you be a better sonographer. All right, so here's your heart, and you need to know your coronary arteries. So you have your acute marginal artery. That's this artery right here where my arrow is. You have your circumflex artery, which is this one right here. You have your left anterior descending artery, which is this one right here. By the way, this one will become the most important artery for you because it feeds both the interventricular septum and so much of that posterior wall. The left coronary artery, which is right here. Your posterior descending artery, which is right here. And your right coronary artery, which is right here. Just remember all these branches and what they connect to. You have to know. So when the patient goes to go get a cardiac cath, they're going to get an explanation. So this will be more of what the patient will be told when they go so they can have a better understanding. It's just a short little video that talks about it to give a better understanding to the patient. But because you guys are students, I show you this because I think it helps you guys along.
Hello, and welcome to Beaumont. Your doctor has ordered a heart catheterization, also known as a cardiac cath. The goal of the procedure is to evaluate your heart vessels and heart function. Your doctor will talk to you about the procedure, but here's some more information about what you can expect. During heart catheterization, the cardiologist will make a small incision in either the groin or the wrist. The cardiologist will decide which is best for you. A long, thin tube called a catheter is inserted into the incision. Contrast dye is then injected through the catheter, which highlights the vessels in your heart It allows your doctor to visualize any blockages, evaluate your heart function. If you have any blockages, a physician will determine whether a stent should be placed. Most people are awake for the procedure, but given medications to help them relax. The procedure typically takes about an hour to an hour and a half, but can vary by case. Before you get started, there are a few things you should either know or do. First, please tell your doctors and nurses if you have any allergies to medications or food. The day before your procedure, avoid caffeine and alcohol and be sure to drink plenty of water. You can eat normally unless told otherwise. On the day of the cath, you will not be able to eat or drink prior to the procedure. Your nurse will let you know when this is to start. You will be given a hospital gown, so please remove all of your clothes, including undergarments, jewelry, and glasses before going to the procedure. You must have one responsible adult at the hospital. It can be a family member or someone you trust to act as your legal representative. This person needs to be there while you are having the procedure in the event the doctor should have any questions. The doctor will also review the results with them. Your nurse will notify you of the scheduled procedure time when it becomes available. This time can change for unanticipated emergencies. Your family or responsible adult will be shown to a waiting room. On the day of the catheterization, you will come to a prep room to get ready. Here, you will meet the cath lab staff. You will ask a few more questions to recheck your health history. You will also sign a consent form. The nurse will monitor your blood pressure, heart rate, and heart rhythm. The device that monitors your heart is called an ECG. It requires stickers to be placed on your chest. A little warning, the nurse may have to shave the chest area so the EKG stickers will stick better. The nurse may also have to clean and shave the area where the tube will be inserted. Next, you will be brought into the cath lab. You'll be in here for about an hour to an hour and a half. It's very important that you will lay flat on the table. A paper blanket, your nurse may call them drapes, will cover you during the procedure. This is a sterile environment, so you must keep your arms under the blanket at all times. You'll be given medications that will help you relax. We will try to make you as comfortable as possible. You'll update your family or the adult you designate about your progress once the procedure is finished. After the cath, you'll be moved into the recovery room for the next few hours. We'll be monitoring your health during this time. When the doctor feels you are safe to leave the recovery area, you will go back to your room or be allowed to go home. Once you are in your room, we will continue to monitor you and keep you informed of your progress. Your nurse will let you know when you can eat and drink again. Please feel free to ask your doctors and nurses any questions. And remember, we are here for you.
All right, so before anything else, you need to know the normal cath pressure tracings. And so when it comes to the aorta, the pressure should be less than 120/80 millimeters of mercury. When it comes to the left atrium of the pulmonary capillary wedge pressure, it should be between 2 to 12 millimeters of mercury. And when it comes to the left ventricle, it should be less than 120, and the diastolic number should be between 3 to 12 millimeters of mercury. So you need to know these normal numbers. And remember, in the cath lab, the pressure tracings are acquired directly from the chambers, and the peak pressures from each chamber are then compared to each other. So we call this peak-to-peak gradient. Also, apart from that, we're able to also determine the mean pressure gradients across the valves in a cath lab. So the mean pressure gradients are the average gradients across that valve. Remember, peak is the highest, mean is the average. So I'm going to talk about this here in a moment. Remember, you get the peak-to-peak gradient, which I just explained, and the mean pressure gradient right here. So let's talk about, before I get to echo, let me just talk about the pressure gradients for a moment. So in order for blood to flow through a vessel across a heart valve, there has to be like a type of force that moves that blood. And the force is the difference between one part of the heart to the other part of the heart. So like from the atria to the ventricles. So the difference in blood pressure is what we call the pressure gradient across the vessel, or the length of that vessel. So we have a formula. And the formula right here is P1 minus P2, which equals the pressure gradient. So the P1 minus P2 represents the pressures between the two structures. So for example, P1 might be the pressure in the left atrium. P2 might be the pressure in the left ventricle. And then the pressure gradient is the difference between the two when you take P2 from P1, when you subtract it. So again, P1 is the pressure in the proximal chamber, the chamber that's before the valve, and P2 is the pressure in the distal chamber. That's the chamber that's on the other side of the valve. Again, pressure gradient is the difference between the two pressures. The velocity is the peak velocity of the flow between the chambers, and then you'll see a number 4, which is a constant. So another formula for a pressure gradient is 4 times the velocity squared. That is a modified Bernoulli's equation. This number 4 will never change, and this squared will never change. The only thing that changes is this velocity right here. So the V, again, sorry you guys, is the peak velocity of the flow between the chambers that we are going to be checking. So it is like the same formula that we used like in the chapter to check pulmonary hypertension, except this time the velocity is not specific to like a tricuspid regurgitant velocity or the right atrial pressure. This is all on page 78 for those of you who might need to go look at it again. Again, remember the number 4 will not change. But before I talk about like how this works with echo, there's a few different things you need to know. One of them is kinetic energy. Kinetic energy is the energy of a moving object, and it takes into consideration the mass of the object that is moving and where it's going. So keep that in mind. Now, the normal pulmonary artery systolic pressure at rest is 18 to 25 millimeters of mercury. The mean pulmonary pressure ranges from 12 to 16 millimeters of mercury. So also keep that in mind. So when a person has like severe pulmonary hypertension, it's going to be like greater than 55 millimeters of mercury. That's when we start to really like, okay, this is bad. We need to care. So let's get to echo. This is the Cath lab we were just talking about. Before that, we're going to do an echo. So when we do an echo, we do Doppler, and Doppler measures velocity. That's how fast the blood is moving and the direction that it's heading in. It does not measure pressure. But you should know that pressure and velocity are related, but they're related inversely. That means they're opposites. When one goes up, the other one must come down. So what it does is it keeps the sum of that potential energy, kinetic energy, and the pressure constant. So again, this is the formula that the machine is going to use to figure out this information that I just talked about. But when we are in the lab, just a quick example. Let's say we were calculating this. If we wanted to know what the pressure gradient was, if the velocity was 3 meters per second, all you're going to do is you're going to put 3 meters per second in here. So you're going to put 3 times 3 is 9 because you're squaring it, and 9 times 4 is 36. So you should get 36. See? It's not a hard thing, but the machine will do it for you. So it's not a hard formulation, but again, the machine will do it for you. All right, so for us with echo, the mean pressure gradient is what we prefer when compared to anything else. Like with the Cath lab values, not the peak gradient, the mean pressure gradient is what correlates very, very well. And we use continuous wave to measure that mean pressure gradient And it matches up very well with cath lab findings, because if you look at this picture right here, the cardiac cath peak to peak measures up very nicely with the echo mean pressure gradient, but unfortunately it doesn't measure up with like the peak instantaneous gradients that we can also get. So one more time, we measure maximum pressure gradient and mean pressure gradient in spectral Doppler. That's when you use the pulse wave Doppler and the continuous wave Doppler. The maximum pressure gradient is going to give you that peak number. That is the highest number of how fast the blood is currently traveling. And that pressure gradient between the two chambers, the left atrium versus the left ventricle, or the left ventricle versus the aorta, depending on the time in the cardiac cycle that you're in. The mean pressure gradient gives you, again, the average pressure gradient that we get from all the velocities within the flow at that particular time in the cardiac cycle within the chambers that you are interrogating or checking.